in the middle of working this. And we created a program called the Public Physiology Research Platform at that time. And it was $7 million of research. Um, and we sought broad capabilities with a public input period during development, which we're playing in now. This is what that is. Something that's hackable and free for anyone to use, whether it's a big company, a small business, an individual, a teacher, a student, anybody. Next slide. And I think I have some of the requirements we put out there at the time. So the first one's that we wanted something that was open source and free for anybody to use without encumbrance. We wanted a general purpose physiology engine. It was primarily for the military, but we needed to work more broadly as well. We were focused on real time, and we wanted something that was equation or circuit analog based, or what I think they call lumped parameter is the term the ARA folks use. But we didn't want computationally intense modeling because we wanted things to be able to run in real time and sometimes lightweight systems. And the solicitation for this specifically prohibited computationally intense modeling approaches that were named. Something hackable that could interface with other things, modular, extensible, something that had multiple systems in it. So going through the process, eventually award was bestowed upon Applied Research Associates, which earned this award for having an outstanding proposal, and they had a physiology engine that they had bought. They had the license and code to start with. So they had a starting basis of an engine that had history that was based on anesthesia and cardiology that had a historical basis back to the 1980s, I believe. Next slide. That was like a 2-year process defining that, like the 2010 to 2012 when put out a solicitation in 2012. And it took a long time. It was not easy. Every time, I mean, this program on the government side almost didn't happen. And it almost didn't happen many times because people wanted to stop it or question it, or they just didn't understand it and why. There are whole departments within the military and scientific community that do modeling, drug modeling, biological modeling, physiological modeling, and they were a different beast because it was not real time, it's computationally intensive, it's research oriented, and it wasn't something that's lightweight that's produces plausible outputs for a training scenario, which is what we were concerned about. And every time we would go to try to get this to the next stage, someone would hit the brakes on us and say, "Oh, you need to talk with the modeling community." And that probably happened no fewer than 6 times. Although the modeling community, people we talked with, understood what we were doing when we explained it, and they saw no conflict. They knew we were doing something different and unique. But it was a difficult process to get this rolling. It was a difficult process to get this awarded, much more than other programs. I think because it was just so novel and different, and people tried to wrap their heads around it. Next slide. Now, the history of what ARA's done with the engine since then is a spectacular success story. I mean, I've been out of government for a number of years, and I've joined as a consultant recently with since last year on this project, which is kind of great to be back into advising on the system again. I remember writing the requirements for it in my office and saying, here's what I thought we'd do. And an ARA solution was unique and interesting and brought in a lot of their own thinking that was just marvelous. But there are multiple approaches to simulating biology. There's modeling systems like physiology engines. There's rule-based systems like state machines. And then there's other types of systems that can be used as well that are often quite practical. And to tell you the truth, I use all of these solutions I've written probably about 50 different applications over my career or contribute to. And along the way, I've used every one of these different approaches. And I give a whole talk on the details of that, but I just want to kind of go lightly over it so you can understand some of the strengths and weaknesses that we're facing. So next slide, please. So my take, and this is from an older presentation, on physiology engine was this. They're high fidelity systems that produce numeric data. They're great for anesthesia, cardiac, etc. And I wrote years ago, it's often not the first choice for medical simulation in games. And one reason for that, it was hard to get your hands on one and to have something documented. And it wasn't something that you could just find good documentation and find something you could buy or use. It was possible, but you had to know people to do it. And so very few people actually were able to use these engines at the time. And then they were tremendously difficult to integrate. They could only handle things in their repertoire. And they're of the three types of engines that existed when we wrote our solicitation back in the before 2012. They weren't, none of them were fully general purpose engines. Like one didn't have drugs, one was very cardiac based, one was I don't remember the details of the other, but they had substantial limitations in their breadth, and required a lot of computing resources. One thing that is sometimes a caveat that you have to consider with a physiology engine is that if they're realistic in what they're doing, sometimes the outputs you get from doing something may be too subtle or slow to happen for educational use. And sometimes when we write scenarios that use them, we have to take that into account, or we sometimes help things along with a bit of exaggeration in what we do. Um, the other thing is sometimes you don't need a lot of fidelity and you could just cheat and produce vital signs you need in a scenario. Um, in that sometimes you do not need this level of sophistication. I think these things are still true, but they are different because some of those assumptions at the time have changed substantially with the fact that there's an engine that's easier and easier to integrate, that's so well documented, that is now so broad in its capabilities, that there's more and more things they can do, more and more systems they can represent, more and more drugs and interventions that are commonly found like a military simulation or a general medicine that you'll find. Next slide, please. So I have in a talk I give about simulating biology various approaches. I actually have a more complex table than this that compares the relative benefits and basically the difficulty of implementation along with the ability for each technological approach to simulate what it's supposed to do. And if you see the leftmost column there is physiology engines. They have great strengths in handling unexpected and complex inputs. And what's great about them is they can you can have an agent, a drug, and its antagonist, and you can give both. And you can do reversal agents, and you can do things stacked on top of each other. So you can do combined things, and the models handle that very, very well. That's why it's really good in critical care medicine and anesthesia, for example. Sometimes correlating that free flow of things with the visualization requires a little more work than with some other approaches. And that how do you know when to represent the patient who's gasping or appearing unconscious or whatever? I mean, there's ways to do that, but you have to think that through. The fact that sometimes the responses are gradual can impair the user's perception of this being high fidelity. And that sometimes when people hit a button or do something in a thing, they expect a response. And that sometimes we have to exaggerate those responses for them to know that a response happens. Sometimes it's really important that you have that strictly medically accurate. But if it's something that they have to wait for 10 minutes for, that's not going to happen in a simulation. You need to have things that show what's going on or ways to show change in the dynamism in your patients. Physiology agents can recover from learner errors very well, which is a great strength. So you tend not to be in a thing where you get boxed in a corner and you can't save the patient, for example. That can happen, but it's not like state machines, which I'll go through, where you're stuck in a corner and you can't get out of it unless the programmer specifically codes a way to get out of that corner. Physiology engines are good for lengthy scenarios. And when I mean lengthy scenarios, I mean up to an hour in real time, maybe representing up to a couple hours. They tend to go to steady state after a while, and they're not really something you want to do to simulate days, although there's ways to do that. The biological fidelity is highest of any of the approaches, but the perception may not be as high because of that gradualness. So it takes a bit of artistry to show that something's really seems to be living. And previous to this, development effort was very difficult. It was a real challenge to do this. I think that's substantially changed now and has improved since when I created this slide 8 years ago. I would say that it's much easier because the engine actually offloads a lot of your work for you, and it's easy to integrate with. And with some of the things we're going to talk about today, it's even easier. There's still challenges in using a physiology engine as a developer, but they're far easier than they used to be. And they're easier than they were even with BioGears 3 years ago. They're continuing to get easier. Next slide, please. So I wanted to talk also about another approach called complex state machines. This is basically where you have a couple of discrete states that represent where a patient is in a, let's say, a scenario, and what their vital signs look like and how they're presenting to you. And generally, you create several of these states and then you make rules for how you change from one state to another. And that's how many medical simulations are made. And it requires a lot of manual programming. I mean, I've been working on tools to make this, to automate this, and to create code for this automatically. But it's another approach to creating scenarios that has advantages and disadvantages. One thing that's nice about them is you get this immediate and controlled feedback from the user inputs. You know, oh, I do these right things. Oh, and you see the patient getting better. You see the vital signs changing, and they change to where the scenario creator wants them to go to. Now, hopefully, they know what they're doing because it goes to whatever numbers they set. It's not based on any real physiology. Um, and if it's done well, it can be very sophisticated and realistic appearing. It does have some disadvantages in that as your scenario gets longer, your programming complexity increases exponentially. So it's very difficult to make a really long scenario or a very complex one because you get more and more and more things you have to deal with, and the exponential growth just overwhelms somebody. So while it might be advantageous in a short, simple scenario, as they get more complex and need more realism, you get to the point where you really want to prefer a physiology engine to handle things as you get to a certain level of complexity. The other disadvantage is difficult to recover from errors. So you can box yourself into one of these states that's hard to get out of. And every one of those steps you need to code. So you need to talk with a programmer or program it yourself. And sometimes it's a 2-week process to get the feedback between you and the programmer. And it's hard to tweak your scenarios sometimes. Next slide. So here's a very simple example of a complex state machine. I just kind of made this up for an example for presentation. But a patient arrives bleeding. You have two choices. One is you can transfuse them, let them still bleed, but they're going to still bleed, right? Whether it's maybe it's internal bleed, who knows? Or you can stop their bleeding, but they're in uncompensated shock, looking at the middle upper part there. Now, if you do nothing, you're still shocking. Even though you stop the bleeding, they could still die. Or if you put them and you give them fluid resuscitation, you can get them this moderate shock state, which might take longer for them to die. Or if you transfuse someone and then you control their bleeding, where maybe they have to open up and do a surgery and stop some sort of internal bleeding, they are still in this moderate shock state. Then you might need to do something else. It could be medications, it could be fluid, it could be surgical to get them to the point where they get in a compensated shock state and then they recover. So each of these boxes represents a state of a complex state machine. Each one of those boxes has its own set of vital signs. So when you do a certain action, you get to a result the author wants. But sometimes it's hard if you get stuck making a mistake. It's sometimes hard to get out of the box. Um, now with a physiology engine, here's the thing. One thing I can do with a scenario like this would be very advantageous is I can just set the bleeding parameters. Like I say, a patient has an injury, and I can represent a graphical patient with a bleeding injury or an internal one. And then I can basically make, the physiology engine will take care of the fact if I do actions in the scenario to stop bleeding or do the surgery, I can send a signal, okay, we stop bleeding now, or you did a transfusion now. So I don't necessarily need to use the states here because I can get very realistic vital signs based off setting the transfusion setting and the exsanguination settings with my model. And the only thing I need to do though is get the patient where they're already bled out and pretty shocky at the beginning of the scenario. So a scenario like this can easily transition to a physiology engine and be very flexible because I'm only adjusting 2 parameters in the physiology engine. Next slide. So here's an example, and I don't see the entire, oh, there we go. So here is an example of states for, let's say, an outpatient asthma exacerbation in a state machine. Now here you see asthma initial presentation. Maybe if it's a speaking patient, they can't hardly say anything. They can just say a few words. They have an elevated respiratory rate, low sats. I give oxygen albuterol. And if I do that, I go to the sum response state. Maybe they can give me a little more information and their vitals improve a little bit. If they don't do those two actions, I go to a bad outcome and you see you sucked as a doctor, go back to school. If I'm in some response, I've given oxygen albuterol, I get some response. If I give more albuterol, I can get to the better response state where the respiratory rate's down to 21 and the sats are at a more reasonable level. But once I do that, with time, I'll go back to the sum response space and keep cycling between sum response and better response, requiring more albuterol every interval time. Now, in this scenario, you've had to give a corticosteroid. And once you're in the better response state, if you've given a corticosteroid, you go to this recovery state and you have a good outcome. So you can program this with state machines and do a very good job of it. There's actually some other approaches you can use as well. Now, if I were to do this as a physiology engine, I can just start with having albuterol, steroids, oxygen, a few other things available with like controls. And one of the things I can do is I can just say set bronchospasm, asthma attack to 0.8 out of a 0 to 1 scale. And now my patient's going to be, they're going to be, they're going to have they're going to have vitals that look like this, right? They're going to be trying to compensate with the respiratory rate. They're going to have low oxygen saturation. And then the medications and oxygen will improve that, and it'll model it for me. Now, the asthma, some response, better response, that will be pretty easy to do. The steroid might require some manual intervention. It might require you to it might work just out of the box with BioGears to give the corticosteroid. You might have to change the model to work more quickly for the sake of you're taking away some medical accuracy to make the scenario happen in time to be educationally useful. So that's where it's more complex to use a physiology engine, in that, yeah, I can get all that automatically without using states, but I can't, I might have to think carefully how something like the steroids would work, because it may not work fast enough for me. It might. I have to experiment with the engine myself to find out how well it works. But I won't have to code a bunch of things. And then what my code and my program will do will be monitoring my vital signs and then deciding based on what I've done if I should get a good outcome or bad outcome, depending on how the patient did. So it's possible to use either approach here. But remember, if this were an ICU thing or something that was going on longer than something I have, where I have more than like 8 or 9 states, I'm much better off using a physiology engine. Next slide. Here is an example of something like this. This was using the predecessor of BioGears, which was the engine it was based off of. This is Human Sim Anesthesia NER, and this is an application we did together where we did conscious sedation and rapid sequence induction of anesthesia scenarios along with anaphylactic responses. And so in this simulator, we had a vital sign monitors as a detail we can do. There's things with airway controls, and there's a whole bunch of game controls here, but underneath is the engine. And we have anesthesia agents. We have a potential for anaphylaxis and the physiology that happens with it, as well as the medications that treat anaphylaxis. And this program had a number of patients, at least 6, and some of them were pediatric, which was challenging. But this is an excellent use of a physiology engine, something like this. Next slide. So I want now to kind of step back and say, let's talk about BioGears strategically. And what's the importance of things that are done with BioGears? I would say that, for example, the goal for creating BioGears was to create a national resource, which is kind of the standard open source physiology engine that people in the country can use. And I think that as far as physiology engines are being used, I think it's kind of done that. And the fact that we're seeing branches of it and unique versions, and we're seeing people we don't even know about using it for very unique and things we never anticipated, kind of show that that vision is coming to fruition. Now, going through the list of what I think are strategically important milestones for BioGears, from my perspective, I'd like to kind of go through those. So we now have a system that's compilable by developers on a variety of platforms. So BioGears is usable if you can get together with developers today. But it works on almost every platform, and it's getting easier and easier for developers. That was important because it basically can reduce production costs and effort for making physiologically realistic simulations. So I think we're at that point. The fact that you can now or will soon be able to save states, where basically you can run someone into a part where they're shocky, save the state, and have that load pretty much instantly, means it's easier for us to create good content because we can start patients where we need them. The other thing is, if we want savable states, we want that because we might want to have multiple ways to represent the patient. And maybe we want to do a multi-D simulation, like for example, with a burn patient. We might kind of independently create various patient presentations and save them so that depending on the progress in one small area, we can go to another saved scenario area to represent longer periods of time than a physiology can otherwise represent. So savable states is a major strategic importance in that you can save, the whole world of the BioGears engine and what the current vitals are, and all the numbers is crunching, and that gives us a lot of flexibility to start where and when we want for new simulations. The fact that BioGears Lite's coming out and can run on embedded systems like Raspberry Pis or some of the ARM-based microcontrollers, things like that. That's really important because we can put it in devices, we can put it in things, and have it in areas even in rural and austere settings. So a light implementation, and actually, I think the original vision, because with all the transport models and things like that, it's got more fidelity than I anticipated it ever have. I think the original vision for BioGears was kind of the light version that exists that they're working on now. So I think it's great that there's a heavier version and a light version. But I think for a lot of practical applications, I think we saw a lot of the military utility with the light system. Something that could run on simple hardware, something that could run multiple instances on one machine to represent multiple casualties, for example. Uh, I know that I'll talk a little bit more about cloud service instantiation, which Austin touched on briefly yesterday. I want to revisit that. I actually got Austin's slide because I want to discuss why that's important. The other thing that we're going to see, that's taking us up to present. Now I'd like to talk about what I think is important for the future. Um, it's great. There's a lot of um, enthusiasm for BioGears as a developer tool. And a lot of physicians, teachers, students, and others are interested in it. But unless you're a pretty good programmer, it's hard to access BioGears directly. And so what the BioGears team is working on now over this course of 2020 is a user interface so it can be usable and experimental by general users, physicians, teachers, students, nurses, whomever. You can actually play with the physiology, you can experiment with it, and actually see what an engine can do, see how things react, learn about physiology, learn how you respond, how insulin and glucagon work, how how cardiac dynamics work, how the respiratory system deals with certain scenarios. I think that's important. And so the fact is, I think that requires a robust visualization, a user-built interface system, and scriptable scenarios. And we'll discuss that in a little more detail. I think another area is that we talked about complex state machines and we talked about physiology engines. I think eventually we will want the level of sophistication where we can hybridize those, where we have a state-based tool that runs the physiology engine um, as needed or in the scenarios that are representing those states. And that is kind of a combination of the two approaches that gives you the advantages of both. Gives you the super high fidelity and the ability to handle all kinds of complex inputs and respond to user errors, but it also gives the ability for the author to take things where they want it to go and handle very large, complex, or lengthy scenarios if they need to do that, like prolonged field care in medicine or a multi-day hospital stay or something like that, or a disease pandemic. Okay, next slide, please. So BioGears on AWS in a Docker container is really, really, really important. And even though I know that someone, I was an intern or student or something, did this, this is really important because once this is on the cloud, you can just call it as a service. And yes, you can call it on any device, no matter how wimpy it is, because it's getting the data outputs from it instead of running the thing. And it means it's infinitely scalable. So if I want to have a mass war scenario and I'm going to have 10,000 combatants and I have 500 casualties, I can create 500 casualties. That's what that means. And so the scalability and the power of BioGears on the cloud in a physiology engine that you can instantiate in the cloud as a service, this needs to be looked at more because the potential power and scalability of this is staggering to me. So when that's, Austin kind of demurely said, "Oh, this is really cool." This is really cool because this will let you do things in places and ways you can't. And I think this is a very exciting development in what we could do. So next slide, please. So I think the one thing I'm working with the team on, and this is a work in progress, is that we need a user interface so that people can actually access this. Clinical people, learners can actually access the engine and understand what power you can get with the physiology engine, as well as learn from it. So these are basically the list of things that I wanted to try to go for with user interface. One is that so they could work on desktop and hopefully mobile at some point and take advantage of the platform. Although I think desktop's the most important of the two for learning physiology. You want a lot of screen space or a tablet or something. You need consistency and ease of use, but you need to be able to have free play where you can play around and tinker, but also a way to kind of save certain sets of tinkering so you can support scenarios. That way you can create scenarios that maybe you could end up using in a simulation later. Or use directly in the UI tool is like a mini medical simulation. You want something customizable so people can go where they want to go with it. You want to showcase BioGears in a way that shows what it can do that other approaches cannot do. So I think, showing graphs is cool, but I think we should BioGears is really has all these compartments and it has all this substance and all this transport. And it's if you actually saw what the code's doing, it's almost like your simulation's a living entity in and of itself. And I think it's important to kind of show that process in motion because that's something that other types of approaches just can't do. So it should appear to be alive and vibrant. And we should be able to showcase that detailed substance information and provide messages of what's going on. So I was going to show you some screenshots of just some prototype things. So when they showed you yesterday the BioGears user interface, it showed 4 graphs and a kind of vital signs display. This is the spreadsheet that was templated off of. And the idea here was we'd have something on the left of the screen that would dock and that we would have customizable buttons that you could create. So you can load like a preset scenario that has buttons to do certain things. Like one could be ingest meal, or infuse glucose, give insulin, give glucagon, whatever you want it to do. But also display variables. And you notice there's a little command line area in the text info display for messages. And the idea was that you could, on the right, you can have graphs, but you also have these tabs of various systems that will try to show what's happening in the life of the simulation. So for example, maybe the respiratory system would show kind of a pulmonary function test running live, but also shows the inhalation exhalation, also shows important respiratory parameters or the amount of how our airflow is doing or oxygen, that. Or maybe our cardiac system shows our cardiac contractility, our ejection fraction, and maybe what's happening between cardiac and respiratory as far as oxygen transport and CO2 and that sort of thing. Maybe about energy shows our energy balance and state and how where that's going. Endocrine chemistry, other substances, a lot of things going on. And so it's not about showing I think it needs to be more than graphs. Sometimes you need to show numbers. Sometimes you need to show some simple animations. Sometimes you need to show graphs. And the example, this is just a sample graph, just meant to show a graph could go there. But the idea is generally, if you've got like a multi your system, you can pop these graphs out in independent windows and kind of show everything you want simultaneously eventually in a system like this would be great. And I think something like that where you can control multiple screens like this on a desktop would be advantageous for people. Could you go to the next slide, please? Now this example mobile. So we have the same display, and you'll see that in a mobile display, you're limited to mostly a vertical orientation. And would kind of think if we were to do something like that, we could scroll the screen up and maybe use the top line to show some of the important vitals, but we could probably fit two graphs on the screen at the same time. Where you can go through the things and you can have a whole stack of these where you can just flick up the screen and get some of those other screens, but you probably couldn't show as much information, but you could show the important stuff in a phone type form factor. Just want to show kind of how that might look, that you'd scroll up and down instead of switching views based on tabs like you would on a desktop computer. Next slide, please. Okay, so this is not an image you will see in a simulation, although I hope we can get around to making something. This is a template for representing a body. It's sort of like a homunculus, and what it is, it's a 2D flattened image of all the compartments of the body. It roughly corresponds to anatomy. So you can see the air outside the patient is a little bubble. You see brain, you see eyes. The purple ones are endocrine glands. You see the heart in the four chambers. You see veins, arteries. I believe the orange stuff's muscle. And then you've got fat compartments, bone compartments, skin, and loose tissue. You've got the stomach, the small intestine, large intestine, represented the pancreas and liver. You can see kidneys. See, the idea is that not that you would show all this at once, but imagine let's say you want to follow the progress of a substance, right? Like what's happening to oxygen in the body, or what's happening to carbon dioxide, or what's happening with when you take a bolus of glucose. Where's the glucose going in your body at any given time? Where is the insulin level? Where is something else happening? Or you give a medication, and where is the medication going in the body? Where is it depositing? And then how is it being excreted? Is it going through the liver? Is it going through the kidneys? Is it being urinated out? So you wouldn't see all these compartments at once. Go to the next slide. Well, before you do that, can you go back to the previous slide? I'd like you to look, I might not be able to read it easily, but you could see the BioGears gas and liquid compartments listed on the spreadsheet. There are many, many of them. And what I'm attempting to do here is trying to combine some of the redundant ones into ones that we could represent in this visualization. Because there's tons of compartments. And for any substance in the body, it'll tell you what the concentration of that substance is in any of these compartments. All right, next slide, please. So here is just showing like if something were exclusively in the kidneys and the ureters and the bladder, that's what it would look like. So you have a lot of it in the kidneys and it's starting to show up in the ureter here. That's an example. So you would see basically the substance visualizer would basically have this graphic of the body, but you would see kind of like a color map of where the substance is in the body. Depending on that layout I showed you on the other page that represents all the different parts of the body. Okay, next, so I don't think that exists anywhere. And I'm hopeful we can do that. It's experimental, don't know if something we'll actually succeed in, but I think it'll be very cool. And I think the impression when it's running would be like, you would see the life of every substance that you could select in the body. You get to see the life of that anesthesia agent you gave. You get to see the life of the metabolic processes happening in real time. And if you have a powerful computer, it might be possible to show more than one of these at once for various substances. This is something that nothing but a physiology engine like BioGears could do because it's really showing all the things it's doing simultaneously. And that's something a state machine could never imitate. Next slide. Now, another thing was a kind of an experiment using the Lua scripting environment. Now, Lua is a language, it's actually from Brazil, and it's used in a lot of video games to script events, and it's a very simplified version of C or Java. It's highly simplified. In this example, this is a coding tool on my computer. And basically, you define some constants. When I use it, I test it on a website that has an interpreter that runs it in real time through my web browser. Um, One of the things that here is in lines 24 and 25, you you could actually register events. For example, how many seconds into a scenario do you want something to automatically happen? Like the person's going along and all of a sudden they're getting a bronchospasm for some reason, or they're exposed to cyanide, or whatever happens. You can set up a series of events that happen at certain times. And then also, there's like a command line where you can type things. Now, anything you can do over command line, you can send instructions from a program or a simulation to something to do, which makes a very simplified way of interfacing with a program. Um, and in the user interface, you see that there's a definition for each button that would hit like line 37 that would basically, here's the name of the button, here's what each button does. Now, it might even be possible to use an authoring tool and have some of this code created automatically in some future situation where you set things up and then the code's created for you. But the thing is that this is a way where that bridges the person who experiments with the user interface and the developer. This is kind of a light coding environment that lets someone who is, let's say, a creator of content or scenario builder, who might be a physician or might be a physiologist, but they know a little bit of how to code things and use logic. This would be enough for them to make a very robust scenario with something like BioGears, yet not be exposed to the full complexity of its development system. All right, next slide. The next slide's a picture of an actual web browser running this code. So on the left is the code for triggering asthma attacks. And actually, there's a common ARA send command to BioGears for a albuterol dose. So to do an asthma attack, this is 0 to 1 setting. So all the code here is doing is it sets boundaries. So you can't set an asthma attack too high or too low. To give you help if you ask for help on a command line where you type in text, as well as to give a default value. So if you just type in asthma attack, the severity is 0.3. And on the right is a series of commands I typed in with my keyboard. So you start up, it says BioGears interface, type help to view available commands. I type in help, and it says BioGears can give you a list of the following: drugs, list of drugs, a list of actions, or you can help with a certain drug name. So I say list drugs, and it shows here's the drugs built into BioGears that you have access to. And then I type in albuterol help, and it says albuterol is inhaled bronchodilator, beta agonist, inhalation occurs over 30 seconds. Examples: albuterol delivers 10 micrograms, whatever. Albuterol 20 delivers 20. And here I type in albuterol 50, and it says albuterol 50 micrograms administer. Or if I type asthma attack help, it gives me instructions how to use the asthma attack command. And so this was all done on a web browser. So this is a concept I'm working for to try to show how you could bridge the two worlds of the experimenter playing with the graphical tools, as well as being able to make scenarios in the user interface so that you can actually make mini scenarios and medical simulations using that user interface. So that UI that they talked about is a place just to experiment. It actually becomes a medical simulation tool that you can actually run pretty good scenarios in potentially. And then the code that you'd use to make that would make the basis of actually a full-blown simulator somewhere. So the power of doing this it basically tries to democratize access to the powerful nature of a physiology engine to people who are more amateur level in their technology skill. And that's kind of the approach of doing something like that. Next slide, please. So I want you to look at not just BioGears, but kind of how these things fit together. Lots of things out there that were funded by DoD or things that could happen in the future, how they fit together. So, for example, Physiology engine and BioGears and all the things going on with that are one piece of a puzzle. When 10 years ago, when I set out and worked with some other people, like the JPC1 committee, people like Kevin Kunkler, and others, we wanted a bunch of technologies to enable each other and work together. So two of the big ones we thought about were the Physiology engine and the Advanced Modular Mannequin type system. And these things require, like AMM requires BioGears to really work and do what it does. but also opens up a whole world of strategic world of things you could do. When I built the virtual standardized patient, the idea was to make it so you could talk to patients and have conversational interactions with them, even though they're physiologically static. You could actually have a robust conversation, conduct a medical interview, or engage in a difficult conversation about opioid use or suicidality, um, and create the technology for that. Um, Also looking at advanced interactions like gesture system for virtual reality medical interactions, or working with robotics or surgical simulator or human sensor integration, or be able to take physiology engine data and help it inform human surrogates during mass casualty exercises in the real world. Those are advanced interactions. I think where this could lead, if we can put all these technologies together and use them as building blocks on each other, we can do really exciting things. One thing I would like to see is something like I call a universal patient, and that's where we take a robust version of BioGears and then combine it with a really good high physiology state tool that's designed to work with BioGears. So we have that hybrid state physiology engine, and then maybe an open injury and battle damage model for the military application. So, for example, um, this is actually something I'm currently proposing to the government, but basically, um, you know, what happens to a bunch of people when a bomb goes off, or a grenade, or there's bullets flying around? Is there a way to kind of automate how we handle that in scenarios? So that instead of writing a simulation for every casualty, I can have a bunch of soldiers, maybe in a synthetic training environment type thing or a mass environment, and the grenade goes off there. How many people are near that grenade? What site of injuries are they going to get? Can logic, computer logic, automatically create casualties for me, and then as needed, bring in cloud instances of BioGears to instantiate those casualties for me? So I'm computationally efficient, and then I need a critical care casualty. I've got my critical care casualty. Or there was a chlorine exposure, and you've got it. What's going to happen with their breathing? So I think that would eventually lead to something called an advanced military non-player character, where we could have we could have a synthetic training environment type thing, but we have fully interactive characters that you can talk to, you can interview or query, you can have how they present and look at, they have a dynamic appearance based on their injuries, and we can conduct casualties at scale. Um, that would require all these different technologies working together, which I don't think is something that's going to happen in the next year or two, but is something that if we work with our government partners to help them with strategy, I think that's something we can get to in the next 5 years or so if we really try. And having capabilities where you have this fully capable interactive characters that can do all these things. They have it would be very, very powerful. And I also think things like BioGears to be able to use useful in schools and education, and say, oh, hey, try someone to see how they're different with emphysema versus someone who doesn't have emphysema. See what smoking does to them. To be able to take that to school kids. I mean, the possibilities are endless. And so that's why I'd like you to think of BioGears as part of a strategic picture. And it's a big piece because it's a very complex piece. And and it enables so many other interactions in so many other areas. It's a huge enabler. Next slide, please. So what I'd like, the way I think of BioGears is I think it's a unique and special national resource, because there's so many things you could do with it. And I think that the way to think about it from technology standpoint and others is in a strategic way of saying how can we leverage this natural resource, how can we conserve it and be able to continue growing it in areas of utility, because as someone asked very adroitly, is like I think it was William said, um, when do we transition where we just use this and don't really pay for this? When it comes to open source tools, you kind of have to, there needs to be a mechanism to keep these tools alive. And part of that light is doing updates, kind of incorporating new things into them, but also sometimes as simple as bug fixes or just being available for the community to contribute. But the thing is that if you went back to the world where we didn't have something like BioGears, every simulation would be so much more expensive to do and would be less reliable and more difficult to build. And so what a platform like BioGears or some of these other tools I've talked about is, it's really a cost multiplier, because it saves money in all the other applications, even though the core capability kind of has to be maintained. And I don't think that's something we've been successful. Um, we've been successful in doing ongoing development for new things and maintaining the code base with that. But I really think we need to have a conversation about open source and how it works with government and the public and private sector, and how we keep it going. Um, because I really think this is a special national resource, and and uh, and I think this is a model how to do some other things where we can make a lot of private applications that use these kind of public parts and building blocks. So I think I kind of hit a few areas there. Do we have time to take a few questions?
Yeah, well, thank you, Brett. That was a really excellent talk. We definitely have a couple minutes to take some questions. If anybody has a question, feel free to type in the chat. I can unmute you, and we can have a discussion. If anybody doesn't have anything else to say, I can at least start us off. Brett, I've seen your virtual standardized patient triage demo, and it's really cool. Have you ever thought about some type of integration of that project with like BioGears simulating the patient, so that not only could you talk to them, you could put a pulse oximeter on them, you could, you know, do the blood pressure cuff and actually measure some of these things that you might measure.
Yeah, yeah, I'll tell you. It was to do the virtual standardized patient would cost more than BioGears cost. It was really hard to do it well.
Yeah.
And I think we did it physiologically static because that's what I mean, it was risky enough doing what we did, and we were pretty successful. In order to do that, we would have to create like a physical body module and something that's live render, which I think is doable. That's been done before. I think we'd also have to make it multi-state, in that there's multiple states in how the character responds. We author each state individually. To do like an AI thing where it changes how it says things at different times would be kind of complex to do right now, but I think that's doable. I think it's getting to the point where that's possible, and I think that something like BioGears would be a good thing to kind of integrate. And I do see part of that because it's what I'm saying would be more state based. I think that combo of state and BioGears together is kind of like a magic solution for some of the more complex things we want to do. Um, and yeah, so that's why in Austin, where I say you mentioned some of these upgrades you did, and you say, well, we can save states now. Well, I don't know if people realize what a big deal that is. Where you say, I can go into AWS right now. I mean, that's a big deal. And both of those are huge deals. But I do think we're getting close where we can do a conversational patient with a physiological patient. I don't think it. I think it would require some funding to do.
Yeah,
But
definitely.
but yeah, I think it's technically doable now. Yes.
Very cool. All right, William, it looks like you have a few questions or comments. I will unmute you. Go ahead. And, oh, wrong William. Sorry. All right, there you go.
Yes, thanks so much, Brett. I really appreciate the talk and the enthusiasm. I'm right there with you. I just want to say that the use of the ISO standard to document in a machine readable format and have that as a discoverable resource on whether or not it's MilCloud in NIPRNet, if you will, or the actual open internet is a great way to get the intentions, results, and the stakeholders of the things that you mentioned at machine speed for those who are willing to listen. And I just strongly advocate you take a look at that particular markup language for strategy and performance plans and performance reports and coordinating what is a Herculean task. I know you aren't going to do that on your own, but to put your own intentions and the results of the works that you've mentioned so far in a machine readable format, I'm more than happy to connect you up with Owen Amber. He used to run xml.org before it kind of faded away as a great way to take some of the friction out of knowing who's done what and being able to discover that in the literature search as folks listen. And of course, when you're talking OSD level, you're talking cost assessment, performance evaluation, Bubba's APE. If you've worked with those guys, they've got to be on your side. And understanding the true value of reallocating resources, especially across the guys who are part of the modeling simulation mafia versus the things that you mentioned before, and looking for that synergy to really come about. I'm a big fan. Again, and you alluded to there's a limit there, but let's talk about what that limit is based on actual population dynamics of combat service members who really generate the work that this audience is interested in, of having them maintain and learn and become stakeholders in their own digital twins. And when people like yourself are looking for realistic scenarios, like you mentioned, with what happens if I'm doing mission planning and something goes wrong, these guys, how do I put together my combat medic, if you will, type loadouts, just like you would for weapon loadout to strike, of what's likely to occur. And I think it's a great way to start a conversation and talking about who do I actually have in the service, and looking at them from a pure data perspective, like the first speaker talked about, simply starting the measurements and sheer bytes or of what I have and what I want to pick from. You guys talk about computational load. We all know about Moore's law. So I'm always kind of interested, especially when you've been around for more than a decade, and Moore's law is still kind of in effect, how that's factored into what it means to computationally low, because that changes as time. And human physiology modeling has an upper limit of how many CPU cycles are needed in other, in the context of computing languages and chipsets and things like that. So those things seem to converge and have a point where CPU, whether or not it's containers in the cloud or whatever you're going to have on your wrist or your arm or in your backpack, it's not going to be an issue. It's the miniaturization of what you can carry into the battlefield is really probably going to be the thrust. So there are, sounds like a dozen or more parallel efforts that need to be coordinated, such that you will start to see major milestones achieved if you can get the people who control the resources and force programs to merge or diverge or go away to help in your effort.
Well, I agree with you. And you had a lot of things there, but I agree with you on standards. I agree with you on data exchange. I think this physiology effort should probably be a program of record somewhere, in my opinion. And I'm fairly confident that this is probably, I'm fairly confident BioGears has saved more money than it cost to develop, just in the applications it's been used for. And I would go on to say that when you talked about the Moore's law, yeah, there's Moore's law, but I think the scale that we can use this for will increase, as well as the technologies it goes together with. So I don't want a program to have it take up more and more space. We really want to be computationally light as possible and maintain that, because maintaining that will allow us to scale it up to multiple casualties. It allows it to scale up with integrating it with dialogue systems or other AI technologies or sensors or models of your virtual doppelganger or projective tools like for your combatant commander, that sort of thing, and unexpected applications. So yeah, I agree with a lot of what you're saying there.
Great. I just think it's important for I mentioned some of the figureheads, in the Joint Surgeon General's office, and the service-specific ones, and then co-meds with the chief of medical around our NATO partners, just to have a few key parameters for folks to to know that we're getting closer. We're getting closer. Whether or not it's the computational part in terms of the gear that we know we have or don't have, and also in the world that I'm in now at Joint Headquarters Doden over at DISA headquarters at Fort Meade. Even just mapping our cyber terrain, because all of this data that you're talking about when you're talking about the military part versus those who are non-military and taking advantage of BioGears, it's part of Doden. And from a cyber protection perspective, we need to know what that is and know what those assets are that could be lost, whether or not it's confidentiality, integrity, or availability for purposes like research, wargaming, and all the other terms that we have for taking advantage of those assets to be used. So sensitizing the community on what that number is, unitizing it to the service member, or like cost-based or activity-based costing, how much data is around a particular procedure or a particular service member and a particular op. I think just hearing those numbers, just the data side, would level set the community. I don't know what they are. I'm not a provider. My wife happens to be a physician assistant, but she's in the public health service now, spent about a decade at Walter Reed in DC and at Bethesda before she left. I think it's just important. It serves both the computer weenies and also the clinical folks.
Yeah. Well, I think when you want to talk to these people, William, I think it's going to be different once we have a user interface and they can actually touch it and see it like it's, because right now we can show them graphs. We could show certain applications that use it. But once you actually can interact with it directly, I think it's going to be, I think it'll have an even better reception. Anyway, I've got to let the floor go here because Austin's going to, and the rest of the team are going to be presenting on multi-trauma physiology. And I'd like to have them let it go of that. But I can be reached at Talbot at ict.usc.edu. And I'm definitely looking forward. If anybody has any questions, I'm happy to take them via email. And thank you for your attention today.
Hey, thanks, Brett. And again, great conversation, William. Thanks for participating. Again, if you have additional questions for Dr. Talbot, his email is in the slides and in the chat. And great guy, does great work, so feel free to reach out to him if you have any ideas or questions.